my screen, and my introduction to her is on my email. But hopefully her introduction goes before her. She is a world leader in Parkinson. She's a clinician in Derby, as well as a researcher on Parkinson's down there. She very, very successfully got her MBE earlier this year, I think it was, wasn't it, Fiona?
Yeah.
And we feel very, very privileged to have her speaking to us on the management of Parkinson's disease today. So I will hand you over to Fiona, and she'll probably do a little bit of an introduction herself, but yeah, I'll hand you over to her now.
Thank you very much, Jane. So thank you for inviting me to speak this evening. What I'm hoping to do is give those of you who know a bit about Parkinson's a few sort of new snippets of things. If you don't have very much experience in Parkinson's, hopefully it will be an overview. Obviously, we haven't got time to go into huge depth, but my intention is to try and give you what it says on the screen, an update. So if I could just have the next slide, please, I'll tell you what we're going to go through this evening. I'm going to give you a bit of information about some of the new things that are coming in how to diagnose Parkinson's. I'm going to talk about medication, partly because there is a new medication available, but also because as physios, you really need to understand how medication works so that you can work out the right time to treat the patient, apart from other things. I'm going to give you some really recent evidence for exercise in Parkinson's, and also just touch on some of the assessment things that you need to know about and some interventions. And then I'm going to signpost you to lots of things you can send your patients to, but also resources for you. Next slide, please. So just waiting for that next slide. Yeah, there we go. So in Parkinson's, we know that it's a loss of dopamine, although there are lots of other things going on as well, but it is mainly that loss of dopamine in the substantia nigra that eventually leads somebody to get a diagnosis of Parkinson's. They won't get that diagnosis until they've already lost at least 50% of their dopamine. It could be anything up to 80%. And we know that there's a protein that misfolds in Parkinson's, which when it misfolds and gets laid down in the brain, it's a Lewy body. And in Parkinson's disease, you get Lewy bodies laid down in different bits of the brain. But in Lewy body dementia, you have a much more widespread spread of the Lewy bodies, which causes a particular type of dementia that also has Parkinsonian features. So we have alpha-synuclein pathology in various bits of our body and in our gut. And there's now a thought that instead of starting in our brains, we think that Parkinson's may well start in the gut and work its way up via the vagal nerve till it eventually reaches the brain. Well, obviously, we can't diagnose it until it's reached the brain, but the process that's going on could be going on for up to 20 years before somebody is diagnosed. So a lot of the research is in about, could we find out what is changing before then, and could we stop it? Next slide, please. So the motor symptoms for which you must have to get a diagnosis of Parkinson's are the bradykinesia, which must be upper body, which is that slowing of speed and smallness of amplitude of movement. So you have to have that in the upper body. Don't get fooled by people who have bradykinesia in their feet. So it's more, but nothing in the upper body, because that's more of a vascular Parkinsonism. They must have the bradykinesia, and then they can have any of the others. So rigidity, which is that ratchety stiffness, or a tremor and a tremor. But only 2/3 of people will have a tremor, and it's a resting tremor, which is a very fine, and it's called pill rolling because that's what pharmacists used to do by hand. So it's not an action tremor, although you will see it a bit as a postural tremor when they're standing. Postural instability used to be an issue for diagnosis as well, but it's been put into a bracket because patients will fall with Parkinson's, less so in the early stages. And we used to think not at all, but we know that's not true now. We know that they do fall, but they've also got very slow automatic responses to being perturbed in their balance. all of those symptoms then lead to things like problems with handwriting, that mask face that is expressionless, not having an arm swing when they're walking, reduced stride length, changes in their gait, and difficulty with transfers and posture changes. So there's lots of physical things going on. Next slide, please. But there's also lots of non-motor symptoms going on, and these often precede the motor symptoms by quite a long time. And people can get lots of different versions of these non-motor symptoms. They're unlikely just to have one, might well have lots, and they fall into those 5 categories. But for the cognitive one, you could have anything from mild cognitive impairment to depression, to anxiety, to apathy, to psychosis. The physical ones are things like, although they're not motor, they are still physical. So you can have irritated bladder, constipation, speech problems, drooling, sensory problems. So there can be a heightened sense of pain. Sleep problems are very common. The circadian rhythm is disturbed in Parkinson's, but also REM sleep behavior disorder, where you act out your dreams. So you're fighting and thrashing in the bed. So that is an indicator now for Parkinsonian condition to be coming on in the future. So they're wondering if they might be able to use that as a prodromal sign. And sexual dysfunction as well is common, particularly in men. So next slide, please. To get a definite as you can be diagnosis, most people, the diagnosis is made clinically, but people can be sent for a DAT scan, and you can see an example of a DAT scan here, which measures the caudate and the putamen, showing how much dopamine active transporter is left in the brain. And you can see the one on the left of the screen there, it's fully there, 2 inverted commas, but on the other one is a much more severe case. It is still asymmetrical, but there is a huge loss of dopamine there. So that is still currently how we do it. But if you can click the next bit of the slide, please. This is what's newly coming. We've got something called seed amplification assays coming, which is where they've discovered that they can actually tell whether somebody's got Parkinson's from their cerebrospinal fluid. And they're now looking at, they're only doing it in research at the moment, but it looks like if they can find a way to do it that doesn't involve lumbar puncture, it might be a really good way of being able to tell if somebody's got Parkinson's quickly without them having to wait years. So what they're actually looking at is see if they can see this alpha-synuclein in those tissues. They're also looking at it in the mucosa of the mouth. So again, only in research, but if that could be done by just taking a swab of the inside of the mouth and tell if somebody's got Parkinson's, that would be that would make a huge difference. But I think we're a while away from that yet, but it is coming. Skin biopsy tests are happening in Australia and 1 or 2 other parts of the world. And that's where a patient would go to an outpatient clinic, lie on a plinth, have 3 little bits of skin taken out by using a little tool that would take a little tiny bit of skin slightly under the surface and send it off to a lab. And 3 weeks later, you would find out if somebody's got Parkinson's. There aren't any labs in the UK yet that will do that, but I suspect that we might well have that in about 5 years' time. And they're also developing a smell test, whether or not you can actually sniff Parkinson's. There is that lady who can smell Parkinson's. She was married to a man and she realized that the smell changed, and then she was actually able to identify people in a group who had Parkinson's from those who didn't. And they've actually trained dogs to do that now. So these are the things that are evolving, which will make it much easier to tell if somebody's got Parkinson's, but we're not quite there yet. So next slide, please. Parkinson's is on the rise, and that's unfortunate, but it's also a really good reason why all of you need to know what you can do for these patients and why you need to still be doing Parkinson's. It's such an important area. It's the fastest growing neurological condition at the moment at all globally, apart from stroke, but it's a fastest growing neurodegenerative condition, and it's set to double in numbers from 2018 by 2065. And nobody's quite sure why. Some people think it's because people are living longer. That's an element, but it's not the whole thing. It is to do with exposure to something. And what is it within our bodies and brains that allows some people to develop Parkinson's and others don't? We think it's to do with neuroinflammation. So there's a lot of reasons, but I think this is why it's so important that physiotherapy is available for people with Parkinson's. You'll know why it's even more important on one of the other slides, which I'll tell you about shortly. So next slide, please. I'm going to talk a bit about medication. And although this might look like a really weird slide, what am I doing with a very nice spa bath on medication? You'll find out in a second. But I think the reason we're going to talk medication is because you might be the person that needs to explain to the patient whether or not their medication's working properly. And also then timing your own intervention at the right time of day for them. So next slide, please. If you imagine it's a bit like a bath full of water, and in that bath you have a level. In this particular bath, this person has a full bath of water and they have a full amount of dopamine in the brain. And if you can just click that next bit of the slide, please, you'll see, hopefully, that you can see that this person's lost a bit of bath water. So at that point, the medication intervention is probably going to be fairly straightforward. But if you click a bit more, the bath level, it should go down a bit, yes. So he's lost a bit more. And as that happens, you need to start adding more medications or changing the dose or changing the timings. So it's quite complex, despite it being quite a neat number of drug types. Next slide, please. So these are the drugs that you need to be aware of, and you can download a free book from Parkinson's UK that has almost all of these drugs in it. Levodopa, most of you will have heard of that. That's still the miracle drug. The miracle in the late 1960s, and it's still the miracle drug. And it's given in various forms. And if you have a patient who is more advanced, much more advanced, they might be offered duodopa, which is it's done directly into the intestines in the jejunum. So there has to be a surgical peg put in, and it's a 24-hour pump. It's quite expensive, but it can be life-changing, particularly for younger people with Parkinson's. But there's the new way of delivering levodopa, which is called produodopa and has got the media in a storm, is done subcutaneously. And this sounds fabulous to everybody, but the thing is, it's not available to everybody. NICE have approved it, but it's only for people who have advanced Parkinson's, who are not suitable for deep brain stimulation, duodopa, or apomorphine, which is one of the dopamine agonists, which is also subcutaneous. So if you have a patient who cannot have any of those for various reasons, it might be orthostatic hypertension means they're not suitable for that medication, then they can be sent for produodopa. These would be patients whose drugs are not optimal. They're struggling with lots of offs, lots of freezing, but it won't just be freezing. But most of their life, or most of their day is in an off state. It is not cheap, but it is, again, effective because it's liquid levodopa bypassing the digestive system and therefore much more active. You get more effect from it over a smooth time scale. You don't get these highs when you've just taken a drug. You get a lot of it in the system and then it wears off. You don't get that with this. And then you have the dopamine agonists that are added in to try and make the levodopa last longer, enzyme inhibitors to try and make the levodopa last longer. That's kind of it in a nutshell. I'm not going to go into the nitty-gritties of the drugs tonight because we haven't time, but if you download that book from Parkinson's UK, it will tell you what you want to know. Next slide, please. What you do need to know, I have just put a couple of other drugs there that you might find your patients are on. Amantidine's an old Parkinson's, it's actually an old antiviral that was used for Parkinson's kind of by accident originally, but it's now a Parkinson's medication. So these, that and anticholinergics are very much used for tremor and rigidity. But rivastigmine's an Alzheimer's drug, but it works really well in Parkinson's to help with mild cognitive impairment. And there's a big study going on at the moment called CHIEF-PD, which is looking into whether rivastigmine can actually reduce falls in Parkinson's. And clozapine is a drug that has lots of regulations around it. You have to have regular blood tests and things, but that can really help with psychosis. The thing you need to know the most is that medication should never be stopped suddenly. And if you work in inpatients, that's something to be really aware of, to try and make sure your patients are getting their medications as and when they need them. There's a campaign at the moment for time critical medications, so all patients should have their medication within 30 minutes of the actual time they normally take it. But it's quite dangerous if it's stopped suddenly. It can actually go into neuroleptic syndrome, which they can die from. So if you are working in A&E or MAU and a patient has come in from an incident, it's really important to make sure they're getting medication. The other thing to be aware of is the impulse behavior disorder that can happen, particularly with dopamine agonists, where people might be shopping compulsively or gambling compulsively, or hypersexual, or taking things apart for no reason, which is what punding is. So just watch out for that. Medication then needs to be reduced. So it's important to let the referrer know the prescriber know as soon as possible. And dopamine dysregulation syndrome is where your patient gives themselves too many medications because they get a big high of dopamine when they do it, and that high feels great, so they don't really want not to do it. I had a patient who used to take almost his whole daily dose before he went on the golf course, and he wasn't bothered about the dystonia and things he got in his mouth and his lips, and he said, "Oh, my golf's so much better that way." It's not very good for you, so just to be discouraged. Next slide, please. The other thing to just understand about medication is because it has that peak when you've got a lot of it in your system, that might be the point at which you have a patient who describes themselves as on. But when it dips and they're maybe wearing off, sometimes that can happen at a time that they're expecting, or it can happen when they're not expecting it randomly. And that's when you start getting these uncontrollable on and offs, when people might start being considered for more advanced medications. But looking at that flow of how the medication works is really important, and understanding that people can get dyskinesia, which is a wriggly, fidgety movement that is uncontrollable. And that's a side effect of medication. So you do need to try and work out when does it happen in relation to the medications, and also be aware that mobility can vary throughout the day, particularly if you're on a ward and you've got a patient who was able to walk half an hour ago, so why can't they walk now? If they've got Parkinson's, it might well be because their medication's worn off. But sometimes other staff on the ward don't always understand that and think the patient's just being difficult. So my tips for this, if I could have the next clip, please, are try to time your intervention according to that medication best time. And next slide, please, and let's pick. If you have got a patient with dyskinesia, which is that wriggly, fidgety movement, getting them to compress upper body hands together, pushing against themselves, that can actually settle it down everywhere except in the head. Or they can push down through the hips. If they're sitting on a chair or standing, feet apart, pushing through the hips firmly will actually settle the whole body down, but only as long as you do it. But it can give them a sense of control if they're in a public place. The main thing you need to do is get the medication reduced. The other thing you can try is blue lens glasses, because if you want to know how that works, Google blue lens glasses and Parkinson's, and you will see some amazing videos on YouTube. But looking through the blue lens actually reduces the dyskinesia massively in a lot of people, not everybody, but it again is another control feature for them. Next slide, please. So now we move on to exercise, and if I could have the next slide, please. We have recommendations that are not going to be a surprise to any of you. But for Parkinson's, not only are there 150 minutes of moderate to vigorous exercise a week, or the 75 minutes of vigorous activity, but in Parkinson's, that should be made up of 3 days of aerobics, 2 to 3 days of strength exercises, 2 to 3 days of balance exercises, and 2 to 3 days of doing stretches. So it's kind of not on top of the 150, but the message is the more exercise you can do, the better your Parkinson's is going to be. And there are a number of places that you can go and look for advice on particular types of exercise and particular things to do at different stages of Parkinson's. Some of them, the fact sheets are on this sheet, but I have put a resources thing at the end of the presentation that hopefully will be helpful as well. So that's what people should be doing. If we could have the next slide, please. We actually know that people with Parkinson's are not doing that. Almost all of them are not doing that. And a study from 2013, I know that was a long time ago, but it's still true that they don't exercise enough. And they're not exercising long enough in each session necessarily, although there is some evidence now for exercise snacking. But when you get to Hoehn and Yahr stage 3, which there's a Hoehn and Yahr scale goes up to 5 for the progression of Parkinson's, but at Hoehn and Yahr stage 3, you're still reasonably active and mobile, and only 10% of people in that study were achieving it at that stage. So that's a challenge. And then this other study, which is a bit more recent, showed that when older people with Parkinson's spent 75% of their awake time sitting down, doing sedentary behavior, and very little of their time was spent in physical activity, and even less in moderate or vigorous. So that's the challenge for us, and it's the challenge for the patients as well, because if we have the next slide, please, the problem is that we know that it makes a difference. We know it makes people physically fitter, more likely to be independent, but it also reduces falls risk. People with Parkinson's are more likely to fracture than people that don't have Parkinson's, so it reduces that risk as well, reduces the chance of them dying so soon, improves self-control, self-image, cognitive function, and ability to stay active in the community. So we'd say what's not to like about it. Can I have the next slide, please? We also know that if you are an exerciser, so for all of you, if you are a regular exerciser or a lifelong exerciser, you've actually reduced your risk of getting Parkinson's, or at least delayed it. So it's a good message for everybody. But even for people with Parkinson's, it's not too late. And the higher levels of exercise that people do in middle or later life, the lower their Parkinson's risk. But doing it when you've got Parkinson's can manage the symptoms. There is potential that it is disease modifying. Now that's really exciting because nothing else is. But we are seeing studies that suggest it's disease modifying. The studies are not strong enough for us to be able to say it is disease modifying, but it's all pointing in that direction. So you can really encourage your patients that they can make a huge difference by exercising. And basically this paper was saying that we should be giving people exercise as medicine right from the beginning. And the NICE guidelines say we should be treating people with Parkinson's right from the beginning. So next slide, please. I think it's that's the pill they should be taking. Perhaps the pill we should all be taking. Next slide, please. This other study looked at, it was a systematic review of observational studies on sedentary behavior, and it ranged from 17 participants in one study to 487 in another, looking at people living at home or in the community. And higher sedentary behavior was correlated with people's cognition being worse, particularly memory and concentration. They were more likely to be depressed. And if we have the next clip, please. Also, if they didn't sleep well, they were more likely to be sedentary. So we need people to be sleeping well, which is why we need a multidisciplinary approach. And speech therapy, occupational therapists specialize in sleep management, which is essential to try and help these patients stay active. Next slide, please. There are also huge benefits within the body. It's not just about motor function and things. There's actually stuff going on in the brain with exercise. And they've found that probably 10 years ago, they were only able to talk about what happened in mice. But now they are able to say what happens in humans. But we know that exercise can make the brain more plastic, reduces neuroinflammation. That's the thing that we think is already involved in causing Parkinson's. So it's really important to reduce that and stop more cells dying. And epigenetics are associated with their sort of DNA is regulates your sort of biological versus your chronological clock. So it's basically if the more exercise you do, basically the more that you could make yourself younger than you chronologically are in your brain activity. So again, what's not to like about it? But exercise also makes the receptors that pick up the dopamine, so natural dopamine as well as levodopa medications, more active and more functional in the brain. And BDNF levels, they are reduced in people with Parkinson's, and that can lead to more degeneration. Well, it can actually improve your BDNF levels. So that's really important as well. I've already said that it induces neuroplasticity, but we know that aerobic exercise particularly does that and can actually change some of those. It doesn't change the structure of the brain, but it changes the activity within the brain and some of that pathology that's going on in there. So it's really, really important. Next slide, please. There's lots of evidence for different types of exercise doing different types of things, and won't be any surprise to any of you that it improves mobility, freezing of gait and balance. Cognition can be improved with exercise. Again, probably not a surprise, but you might be surprised that it actually can improve fatigue and apathy. So it's important to understand that, because one of our jobs is to try and help patients to be more active and exercise despite and alongside the fatigue and the apathy. The little bit of exercise can actually help the fatigue. So rather than saying, well, why don't you stay on the sofa and just rest? We want you to be a little bit more active, because that actually will help your fatigue levels. Improve sleep, mood, anxiety, and apathy. Again, that was the same paper for the apathy. Memory and quality of life. So no surprises there. Next slide, please. The thing is that there isn't any one type of exercise that is better than another. Lots of people have been looking at different ways of seeing if they could find out if one is better than another. We do know that aerobic is better for things like cognition, and the intensity of the exercise is quite important, and the endurance, or the length you do it for, and the frequency that you do it. And but they all have different elements, and you need all of them. So it doesn't really matter what you recommend to your patient, as long as they are exercising, and exercising to a certain level if possible. So that paper is there just to show you that although they've looked at lots of different things, they all had benefits, but no one over another. Next slide, please. So there is evidence, and I put these on a reference Word document for you that can be sent around, that there's evidence for boxing, Tai Chi, strength resistance, high intensity, Nordic walking, and the next clip, please, which you can think about on Saturday nights, Dancing. There's lots for dancing. Dancing has great benefits. There's a bit of cueing involved, balance involved. You've got a partner who's hanging on to you. So whatever your patient is interested in, they are going to need it to be something they like and for it to be fun. But there is evidence for so many different types of exercise. Next slide, please. Even immediate effects can happen as well. So they've looked at cycling, and they had a PET scan with somebody who'd just done a single bout of intense cycling. These were people who normally were exercising a lot, but they found that that single bout of intense cycling gave them more dopamine in their caudate nucleus than people who were sedentary. Now, remember that caudate nucleus, you can see the picture of the DAT scan on this slide. That's where you need that dopamine to be staying. So it's boosting the dopamine. And then another bout of high intensity, again, cycling, had immediate improvements in motor symptoms of balance, gait, and upper limb coordination. So that patient might not immediately notice the benefits, but they might. So it's things that we can use to encourage people to be more active. Next slide, please. And keeping up with the times, virtual reality is becoming a thing we're starting to hear about, certainly in research places that they've got virtual reality happening. But there are also physiotherapy departments where virtual reality is being used. And some of you may have heard of the Stroll headset, where that can be used for all sorts of different things. We're going to be doing a study of it in Derby. But basically, the patient is wearing a headset and you can pick what they see, but they might see pillars in the room that have got vases on. They've got to go around punching the vases off the pillars, which does look bizarre when you're not wearing the headset and maybe looking through the window. But there are lots of other ways that can be used. So that is evolving. And there's evidence as well for exergaming in Parkinson's, also improving hippocampal volume. And I can see that question at the bottom just about cycling. Yes, it can be done on stationary pedals as well. It's about the speed and intensity of the cycling. But again, that is around how active is your patient already. You have to start where they are. Next slide, please. This is just to give you an example that is in the book that Banu Ramaswamy and Julie Jones and the other name has escaped me at this precise moment, but an excellent physio in Newcastle put together a chapter on exercise. And there's a table that will show you the different exercise types that you can do with the recommended doses. It was Catherine Baker, it's come back to me. Recommended doses and what the researched examples are. So you don't have to invent it yourselves. You can get lots of ideas from different places for the kind of things that you can offer these patients. Next slide, please. However, not everybody wants to exercise. And our challenge is we're trying to help patients who've got motor symptoms, maybe not expecting to get better or to have a benefit from the exercise or not expecting to enjoy it. They might be frightened they're going to hurt themselves or fall over. They might have apathy or anxiety or fatigue. It might be that they haven't got the space to do the exercise, or the social environment isn't right. There's too many people in the house or not enough people in the house, or they've just no idea what to do. And quite a lot of people who were really active just before they got diagnosed with Parkinson's have had either such a shock because they weren't expecting it, or as they've been given the diagnosis, the process of trying to come to terms with it, they've just stopped exercising altogether, sudden stop, and then they've no idea what to do. So our job is really to try and help them re-engage with activity as quickly as possible. Next slide, please. So some of the things that you can offer these patients are obviously helping them to be self-efficacious, so they need to be in charge of it themselves. There's no point in us saying you must do this. We can say this is why you could do this or you should do this, but they need to be responsible for it themselves. So it's us helping them to understand why they need to do it. I'm a great one for the carrots and the rewards. So I'm usually telling patients, why don't you put a time in that you can do your exercise? It's maybe just before your morning coffee and cake, and then have the cake after you've done the exercise. The thing for us is maybe to think about the words that you use. So if you've got a patient who doesn't like exercise, use the word activity. Try not to use the word exercise before you use the word activity, because that's what they'll remember and fix on. But it's the card, love activity, hate exercises, from a CSP campaign. And it is, you know, the words we use are really important. You could use motivational interviewing as well if you've done some training in that. Manage expectations. You know, you can have the patient who's not expecting to get any benefit, or you've got the patient who thinks because they have gone for a walk today, they're going to be able to walk a marathon tomorrow. Manage the expectations, adjust for the disease severity, but build progression in. An exercise buddy can be helpful. It's not always easy to do that because of sort of confidentiality and things, but if they can find somebody to go with or exercise with online, you can do things online or with DVDs. If you go to the Moving Medicine website, you can get some ideas about how to have conversations with people about exercise. I think the Moving Medicine is a really good website for health professionals. It's probably one that is more aimed at people who are not physios and exercise professionals, but it's how the consultants and the nurses and people can have a 1-minute conversation with somebody about activity, or a 5-minute one, or a 10-minute one. But I think you'll also find that there's some really useful tips in there, and it's quite a fun website too. Next slide, please. Make it fun, because if it's not fun, they're not going to do it. Next slide, please. So I just put this bit in because this is another way to overcome a barriers to get there is increasing evidence coming that snacking can be just as well, it can be beneficial. I'm not sure that we can say it will be just as beneficial, but exercise snacking is something that patients could do in 10-minute bouts. And this is one study that this wasn't Parkinson's, but it was older patients who were in a memory clinic. And basically it showed that the patients didn't have to do very much because it was just 1 minute each for 5 muscle strengthening exercises, but they had to do it twice a day for 28 days. And the patients actually enjoyed it and did it, felt it was effective, and it wasn't too much bother. I think there are other papers coming. Meg Morris has been talking about exercise snacking for about 12 months, and I think some papers will be evolving. Meg Morris is a professor of physiotherapy in Parkinson's in Australia, and in my world, she's the queen of Parkinson's, really. And I think it was really exciting to hear that that's something that we can offer the patients, because not everybody wants to do half an hour or an hour when they have to do their exercises, or even 15 minutes. You could do it in 10. Next slide, please. So we're moving into the assessment and specific interventions, just to give you some tips in this area. Next slide, please. I think the most important thing is to make sure that you are using outcome measures that are validated for Parkinson's. The audits, the Parkinson's UK audit has identified that a lot of physios are using Parkinson's outcome measures, but quite a few that did the audit are not. And to do the audit, you need to have at least 10 patients with Parkinson's in a 5-month period. And it's not to try and sort of pick out where people aren't doing things right. It's help services or individuals develop their skills and know what they should be doing. But we did find that not everybody was using all the recommended outcome measures. So go to the European guidelines for a comprehensive list. And things like the UPDRS isn't very helpful for physios, but it is used in research, so be aware of it. You may have heard of the Lindop-Parkinson's assessment scale. It's a functional mobility and bed mobility and gait mobility scale, which is useful in a clinic setting because it's quick. But there are plenty other things that are much more detailed. The mini best can be very good for your fitter, younger patients. But we should be looking at all these areas that I put on this slide and assessing them. You may not get through all of that in your first session with the patients, but I would say always ask the patient, what is your biggest problem? You do need to get your assessment done, but you also need to address that most important thing for that patient. And that might mean deferring a bit of your assessment for the next time. Next slide, please. That's just a picture of the European guidelines. So people with Parkinson's, their dorsiflexion is not as good as people who don't have Parkinson's. And that is then associated with their walking speed, and they're more likely to freeze. They also have a lot of them have impaired ankle proprioception. So it's really important to look at people in their bare feet, but also then to try and address these gait problems because they've got reduced stride length, reduced ground clearance, and it's harder for them to do two things at once or more than two things at once. So you need to assess that as well, because that could determine their propensity to falling. Next click, please. So the interventions are things like using visualization cues, which is imagining something that's there to walk around or to step over. You can use stripes on the floor or post-it notes through a doorway so that somebody focuses on the post-it note beyond the doorway so they don't freeze in the doorway. Have a laser pen in your pocket. It's a great thing for pointing at the floor, and patient can step onto that to do a gait initiation. You could say big steps in a bossy voice. Does need to be a bossy voice. Or you could use a metronome or some music set to the right beat and the right speed for your patient and what speed you want them to walk to. Next click gives a couple of other just tips. One way of addressing that heel strike and gait problem in a session is get the patient to imagine they're walking on the beach in their bare feet and they want to leave their footprint in the sand, and their heel strike will almost immediately improve, partly because they're giving attention to it, but also because it will improve. If you have a patient who hasn't got a good heel strike, and it looks like that might actually interfere with their stability, if you've got the possibility of referring them to a gait lab, that's also worth doing because a functional electrical stimulation may be suitable for them. And there is a big study going on, multi-center study, in whether FES is helpful to patients who've got gait problems. And also getting them to wide walk within a clinic setting, practice that can help as well. It depends on your patient and their gait problem. Next slide, please. I'm aware of the time. I promise not to keep you. We'll whiz through these. For freezing of gait, you need to find out when it's happening, get them to recognize when they're on their toes instead of on their heels. You need to address turning. It's one of the things that leads to falls. So things like marching when they're turning, or using a laser on a walking aid, or they could follow around the laser pen, and think about that geotasking, whether it needs to be trained. There are some apps you can use, or whether it needs to be avoided. And you will find that table in the book that I'll point out at the end of the talk. Next slide, please. Just as I mentioned earlier, Parkinson's patients are more likely to break a bone. They're more at risk of osteoporosis. Their vitamin D levels are not as good. And so falls are a bit more catastrophic for them. They're much more likely to break their hip. And they're much more likely to stay in hospital longer, and they're much more likely not to do as well after the fracture. So next slide, please. As a result, there are things that you can do to try and prevent those falls. So you can address dyskinesia, or it might be that you that's picking it up, but if somebody has dyskinesia in their feet and ankles, it's going to make them unstable. So getting somebody to look at their medication. Gait and balance impairment, address that, address freezing. Beware of orthostatic hypertension when the blood pressure drops, because that happens in Parkinson's anyway, in some people, and it also can happen with the medication. So you've got a double whammy. So there are various things that you can do about orthostatic hypertension, which I think I've put on the next slide. Deal with fear of falling as well, and managing cognitive impairment. Next slide, please. So orthostatic hypertension, your patient may well feel dizzy, but they might not. They can get it without symptoms. If they are having symptoms, it might be that it blurs their vision as well, or gives them a foggy head. Coat hanger pain is where the blood, if you were imagine somebody was wearing a coat hanger, that's where the pain is. And it's because the body is trying to get blood back to the head, and it's taking it from these muscles. If they lie down, that pain usually goes off. But it's being aware that it might not be a cervical spine problem. It might actually be orthostatic hypertension. Their voice can go very quiet as well, and they might ultimately pass out. So next clip, please. Avoiding alcohol, because that can make it worse. Large meals make it worse, or even exercising after large meals. Hot rooms can make it worse. Obviously, you'll be aware of sudden changes in posture or standing for a long time. So advising patients to avoid these things. Next clip, please. And then encouraging them to drink enough fluids. That's often one of the biggest, not causes, but things that's involved. Increasing salt, if that's safe to do so. Constipation is a biggie. If people have got constipation, the chances are their medication is not going through their body correctly, so they're not getting the benefit from it. So it's probably the number one thing that needs addressing. So exercise can help that, but they might need pointing to the Parkinson's nurse for some advice on laxatives and things. There are some things like abdominal binders. They're not hugely successful, but they are spoken about, so I'll tell you about them. Sipping water can help bring the blood pressure up fairly quickly, and there are some physical counter maneuvers you can do. The quickest one to tell you about tonight is to do like a Chinese burn on your own arms, but without the twist. So it's not a Chinese burn, it's a Chinese pull, but you're basically trying to pump your biceps to get some blood up to the head, so they can do that sitting down. Next slide, please. So when it comes to transfers, patient actually physically can still do a transfer, but they have lost the automaticity to do it. So you break down the movement into component parts instead, and you get them to bring their bottom forward, feet placed, hands on the chair, arms if they're on one, and chin forward and up. And if I have the next click, you'll see a helicopter. They should not come up like a helicopter. None of us can stand up from a chair like a helicopter. So next click has a big cross over that. And then the next click has an aeroplane. They come up like an aeroplane. I got this tip through somebody on the exercise hub. It's the best tip I've had in ages. And patients can really identify with that. They can get that picture and they come up like an aeroplane. Much easier. And they suddenly think, oh, I can do it after all. They're usually forgetting to bring their bottom forward. And the next clip, please. In terms of bed mobility, again, you split it up into the component parts of the movement. But the other thing you can recommend is a satin strip on the middle bit of the bed. If you click again, I think there's a picture of yeah. So you can put, like that blue bit is the satin strip on top of the cotton bottom sheet. And then the patient can slip their bottom round. It's much easier in the middle of the night. Next slide, please. You can also do that the one that you just saw flashing by as a cue card that you can actually write for transfers as well. So you can study that on the PowerPoint, which will be sent out as well. Thank you. Write it in a diagonal because it's easier to split the bits up, and different colours help as well. Posture can be a major issue and you need to catch them early. Measure it early so that you know what it is. So you can see the tape measure. If we perhaps have the next click there, it just does mention about the taking that tragus to wall measure, which is they stand against the wall, heels up against the wall, bottom and shoulder blades on the wall, and you measure from the wall to the soft triangular bit on the front of the ear. That's your tragus. And that gives them something to aim for. And you can actually improve that measurement even in your first session, if you, depending on the posture, but if it's a more of a flex posture and they can't get their head on the wall anymore, you can all go and practice trying that when you finish this. You can actually, when you get them moving their thoracic spine and their scapula and their pectorals, you can actually improve that, and that encourages them. There are some bigger problems in posture, like an anticollis, a head drop, or Pisa syndrome, which is the sideways one, or camptocormia, which is a 45-degree angle. If it's pure Pisa syndrome and pure camptocormia, they correct when you lie down. But if it'll be a scoliosis and Pisa syndrome if it doesn't correct. Think about how many pillows the patient uses, ask them. So the fewer the pillows, the better. They need to be comfortable, but the fewer the pillows, the better for their posture. Think about the posture in their sitting as well as standing. Lots of big exercises, getting these big movements. I put furniture adjustments there, so getting them, if they always lean to one side and the television's over that side, get them to move the chairs around so they're looking the other way. Next slide, please. So finally, for the last minute or two, just pointing you to some resources and signpostings. Next slide, please. So there's the Excellence Network, which you can join up for free from Parkinson's UK, and you will get a forum there where you can ask questions, you can access free courses and things. It's really, really worthwhile joining. It's an excellent network full of lots of different health professionals, and you will find that there is a clinical region that you are in somewhere that has got a new Excellence Network. We've just relaunched the networks in different parts of the country with leads where there will be regional meetings and things. So I definitely encourage you to email Parkinson's UK to join up there. Next slide, please. You can also find that there's a learning pathway for therapists, which is a directory that you can go to for courses that you can access free, or information leaflets and things. Definitely, you can go and explore that. Again, it's free. Next slide, please. There's an app library. It's not recommending particular apps. It's an app library where any app that has been mentioned by somebody gets put in there, with patients will say how they found it using it. So you'll either have good or not so good feedback, so people know what kind of apps they can use. Next slide, please. There's an exercise hub, which is full of exercise professionals, people with an interest in exercise. So physios, but there's also lots of other people doing various exercise for people with Parkinson's. And that has a monthly webinar, which is free on a Tuesday night, second Tuesday of the month, and a study day once a year. So very much recommend that. Next slide, please. Signposting your patients to exercise. There are a number of things that they can do as well. There's Neuro Heroes and Reach Your Peak are both doing online things for people with Parkinson's with special offers. And I think the Neuro Heroes are doing a free one for the first number of weeks. And then there's Power Moves, although you do have to be licensed for that now. And there are things like PD Warrior. You can sign up to do the courses for that. Next slide, please. Your patients can get free membership of the Everyone Active gyms. So all they need to do is go along to the gym with a letter that proves they've got Parkinson's. And if you do the next click, there's also Pure Gym doing it now as well. So you can point your patients in those directions. If they go on the Parkinson's UK website and put their postcode in, they'll find them. Next slide, please. There's other things that are happening all over the country as well for Parkinson's: walking, football, golf, pickleball, boxing, and walking cricket, to name but a few. So lots of things that you can get your patients into to get them socialising and active. We've just started a walking football in Derby. Next slide, please. Parkinson's Foundation has some resources for physiotherapists as well. That's the American equivalent of Parkinson's UK. Next slide, please. And Training Made Easy are running the courses that we used to run in Derby. They're still running them for us in Derby, but it used to be done by NCOR. But there's a course coming up in a couple of weeks for people that don't have very much knowledge of Parkinson's, a one-day course. And there's also an atypical Parkinson's course coming up in January, which again will be in Derby. So I put you the details for getting more information, or if you want to sign up for them. Next slide, please. I think it's nearly the last one. It's just to point you in the direction of a handbook for Parkinson's that's been written by a number of different health professionals who all specialise in Parkinson's. And I co-edited it with Dr. Rob Skelly, and we wanted it to be affordable. So most medical books are often over £100. But ours is at its full price, something like 33 or something like that. But it's often on special offer on Elsevier or Amazon. But your library can probably get it for you as well. But you can go to the index if you want to find out about, how to what to do with a patient who's got a continence problem, or what to do with a patient that's got a different problem, and you'll find the answer, I think, in the book. Next slide, please, which might be my last one. Yes. Poof, just in time. Sorry, it doesn't leave you much time for questions, but if you do, for lots, if you send me lots of questions, I'll try and answer them all and write the answers down.
Yeah, I mean, that was absolutely wonderful, Fiona. Thank you. I've learned lots and I've been scribbling down, but that was brilliant. So thank you so much. Really, really appreciate it. I suppose, I'm happy as long as you're happy to stay, Fiona, we can take some questions. Yeah, perfect. So if I come back to the main screen, I think we've got a couple of Agile North members that are going to kind of go through the chat. If you do have any questions, feel free to put your hand up, or kind of pop your question in the chat and we can try and come to you. I know there's been some that have gone on while we were sharing. Emily, do you want to see what we've got?
I would just say while you're finding it, I know it's a whistle-stop tour of Parkinson's, because we could talk about it forever, and you can go so deep. The other thing that Training Made Easy do is a 2-day course, which we've just done it, and won't do another one until next year. But I've kind of given you the skimmed version. There's so much more, but I hope it wasn't too fast. But I just wanted to give you snippets that you could go away with.
Thank you so much, Fiona. It was really helpful. We've got a few questions in the chat for you. One's from Louise Woodside, and it's about the blue lens glasses. She works in the community with little access to exercise equipment or specialist equipment. Do we recommend patients self-purchase these? And if so, where would they go about that?
And what was the equipment? Was it laser aids, or was it?
It was about the blue lens glasses. This one was.
Yeah, I think what we've done in our department is we bought some cheap on Amazon for the department, just have them to patients try them on there and then. I'm reluctant to recommend that patients buy them until I know whether they work, which is why I like to have a pair. You can, I managed to buy a pair in that Tiger shop at one point, sunglasses. They're usually sunglasses that are blue tinted. And you need to make sure it's the lens that's blue and not just a painted blue on a black lens. But we bought them for £3 or something one summer. But you can buy them on Amazon. So if you just had a cheap pair that you could try on a patient, and if they work, then the patient can then decide if they want to go to the optician and get their own glasses tinted, or just buy some on Amazon.
Okay. The next question is also from Louise. It's asking what your thoughts are on the beach band tapping.
Beach band. Oh, is this the BEE beach band from Coral Beach? Yeah, I think it'll be interesting to see. When Parkinson's UK have sort of got behind it. I don't know enough about it yet to know how effective it's going to be, but I think Parkinson's UK don't usually get behind things that they're not fairly sure are going to be really sort of innovative. And I think Carl's managed to get quite a few people behind him on this. So I would watch the space with that and see what happens.
Okay, another question from Louise asking about whether we recommend self-purchasing of laser pens or laser sticks for patients.
Well, I think a laser pen is worth, again, you having one in your pocket so that if it works for the patient, they can then go and buy one. That's what we tell ours to do. A laser stick would depend on whether your patient needs a walking stick in the first place. But you have to bear in mind that you can't see the laser with the walking stick outside. In bright daylight, it doesn't show up. So we've got a laser cane in the department that we can try with patients, but we don't have very many people that really find that useful. The U-step is much more useful for people. But a laser pen, I do think, is a useful thing. And you can have it in your pocket, but if it works for the patient, or their carer could have it, but it might be somebody that doesn't need a walking aid, has a free hand, and can just have it on a lanyard around their neck to press if they get stuck.
Okay, next question from, I hope I'm pronouncing this right, Nimalini, and it's asking whether carers also get free membership to the gyms.
They do if the patient needs help in the gym, then yes, I think the gym does give free membership to the carer. If the patient with the carer bounce into the gym both looking like they're going to go and have a great aerobic session, they might be a bit more likely to go. The carer can't come. They originally said they were going to give it to the carers, and then they started reneging a bit on that. So it might depend on your actual everyone active gym. But there are certainly circumstances in which they will give it to the carer.
Thank you. Next question's from Aslan, and it's asking what percentage of Parkinson's patients go on to develop cognitive issues. But they've seen a lot of cognitive issues recently.
I'd say almost all of them. Mild cognitive impairment is quite common early on, but that's just sort of the processing thinking. But a lot go on to develop more cognitive problems as the condition progresses. But that's another reason why we should be promoting exercise, because perhaps we could delay that by keeping those neurons in the brain more plastic and less inflammation. But yeah, I'm afraid it's it can be quite a high percentage, not 100%, but it is high. It's higher than it should be, and I think probably because we haven't fully understood. I think 15 years ago we said that, you know, it wasn't that many and people weren't cognitively impaired at all at the beginning, but it's not entirely true.
Thank you. Next question's from Victoria, and she's noticed that with an LD patient who's gone from having lots of movement and behavioural changes, they're now quite withdrawn within 3 days of medication change. Is that normal to see medication effects so soon?
So are you saying that the medication was that a negative change in there? They're more withdrawn in themselves and
yeah, and
yeah. That doesn't sound very good. And if there's a Parkinson's nurse involved, I'd get in touch with the Parkinson's nurse, or I'd get in touch with whoever prescribed the medication and say, we've noticed this change. Quite important to do that as soon as possible.
Thank you. There's one from a guest, and it's saying that a colleague has recently said we shouldn't be doing strengthening exercises in undiagnosed, unmedicated Parkinson's, but likely Parkinson's, as it will increase rigidity. What are your thoughts?
I've never heard that before. So that's a new one on me. I don't think that's true, because it's not going to do any harm. Unmedicated patients need exercise as much as anything.
Okay. Just going through now. About carers, we've answered that.
There's lots of people saying thank you very much, and it's been brilliant, Fiona. So yeah, thank you.
Thank you as well for doing the slides, Jane, because we had a problem at the beginning, but we've overcome it.
Are there any more questions?
I think there's just one more. That's from Andrea. She works on an acute frailty ward and has many patients with severe symptomatic orthostatic hypertension. Do you have any best advice on how to manage this other than ensuring medication's optimized, adequate hydration?
It is really tricky. There are some tips you can do, like tipping the head end of the bed 15 degrees, so the patient sleeps not flat but at an angle. Binders might help with that. There's if you want to really know the lowdown on that, the atypical course we're running in January has got Catherine Best speaking at it, and she's an autonomic nurse from King's College London, and she'll be speaking about that. And she's the person I go to when I get a patient I think I don't know what to do here. And she's got huge number of tips, but there are sometimes, you know, particularly if you've got a patient who's cognitively impaired, it's difficult. But you just you do need to try and address medication, so they might need midodrine or something to try and bring their blood pressure up a bit. But other than that, you're looking at techniques and times of day and things like that.
I think there's also a question a bit further up, Fiona, from Nicola, saying that her patients often don't get referred to her until they're very symptomatic and restricted. So it can be tricky to balance exercises with safety. Are there any tips?
See if you can get your referrers to refer earlier for a start. And then I think you do have to balance safety. So seated exercises, you can still get patients to do things in a seated position, or in a lying position, or on all fours if they can get off the floor again. But that is probably one of the reasons for encouraging your referrers to refer early, because it's far easier to prevent something and to push the exercise while somebody's safer on their feet than it is to have to address all the problems as they come along later. And that, you know, it's against all the advice to do the referring later. The other challenge is that some physiotherapy services say, oh, we can't have the patients until they've got a problem. But if you don't see them, they've got a problem pretty quickly.
Thank you. I think that's all the questions.
I think there's a couple more now, Emmeline, right at the bottom.
Okay, Jane, if you want. There's another question from a guest. And what other advice would you give the patient who choose to manage Parkinson's without meds?
The latest evidence is that there is not a benefit in not having the meds, in delaying sort of having them or having a different medication to start with. So the problem is that if they delay having meds, the degeneration's still going on, so they might actually not be getting the benefit that they would get from the medication, or by the time they do start medication, it's not as beneficial. So that's the first thing I might say is, you know, think about, you can't ever say to a patient you should take the meds, but you do need to give them the information so that they understand it and understand the choice they're making. But then I would say that the best thing they can do is exercise. If they don't want to take meds, then really the medication is that pill of exercise every day.
Okay, I think I've got a couple at the bottom here. Joanna Milton's asked, she works in inpatients and often get patients with blood pressure problems, and sometimes feel patients go from mobile to not mobile. Medicine maxed out, still struggling with blood pressure. Is this often the case?
It is often the case, but the problem is that they then get left in bed on the wards because they're not, and the ward staff are often a bit frightened about getting them up. So we've got a physio and an OT who we got Pump Prime bid from Parkinson's UK for them to go onto the wards as a rapid service, and they spend some of their time going on the wards to get people out of bed and into chairs. Obviously a graded move from lying in a bed to sitting on the bed to ultimately getting into the chair, but to try and get them up, because the longer they stay in bed, not out of bed at all, the worse it's going to be. So trying to do those changes of position as soon as they possibly can, and then it's things like making sure that they've got enough hydration, the room isn't too hot, you've chosen the right time of day, it's not too long that you're working with them, but they do spend quite, I mean, I'm sure if you wanted some advice from them, if you email me, I'll put you in touch with them and they'll tell you what they've been doing on working at that.
Yeah, thank you. Another one at the bottom here is asking how cardiac conditions limit ability to engage in intense exercise.
That's an important point, and there is there is evidence that Parkinson's somebody with Parkinson's heart isn't able to maximize to the same level that somebody who doesn't have Parkinson's. So you need to know your patient's medical history, but then finding again the thing that they can do within whatever their cardiac limitations are, if there's a reason why they shouldn't exercise beyond a certain level. But otherwise it is about trying to avoid that sedentary behavior and get people doing that little bit more. I will often say to a more sedentary patient, if you go for a walk every day anyway, could you walk a bit more briskly from one lamppost to the next, just to get yourself a little bit out of breath? But I'm not asking them to go for a run or a marathon. So it's just finding that little something that they can do that just is a step in the right direction.
Brilliant. Sarah Jane's asking, she works in an intermediate care unit and they struggle to monitor the Parkinson's disease symptoms over 24 hours and a dose response. Do you have any tools or suggestions on how to manage that?
Is that the individual patient that, or yeah? I think there are devices out there that people are developing to look at 24-hour monitoring things, but there is, somebody has made an app. So if you went into the technology bit of Parkinson's UK, somebody with Parkinson's has made an app that people can put on their phone that actually will monitor some of their symptoms, I think, and it's in development. It sounds like it's going to be quite interesting. But I think otherwise it's a case of looking at things like if it's looking to see if they're getting the medication on time, is there a medication timer? We have an electronic prescribing system, so people can go back and look and see that somebody's got the meds on time. But otherwise it might be making friends with somebody on the ward, another health professional who can make a note of something. But probably you're looking for technology to do that job otherwise, which is tricky. There's lots of people trying to develop things out there who are all claiming it's the best thing since sliced bread, but one or two are.
Thank you. Oh, another one's popped up. What's your view on slow release versus non-slow release meds?
Well, slow release meds tend to be used for things like overnight, so people can get out and go to the loo. They last longer, but they don't have such a big effect. So if you've got somebody who needs to take a tablet and then do more before the next one, then they're usually an overnighty thing. I don't think there's one better than the other. I think it depends on the individual and what their needs are.
I think that's all the questions. Have I missed anything?
I've got a cheeky question, Fiona, if that's all right. I was just wondering what your views were on neck collars with anticollis.
Yes, anticollis is a tricky one. You need to know why they've got an anticollis first, and just be aware that anticollis is a red flag for multiple system atrophy, but it is also a thing that happens in Parkinson's. And if it's happened soon after a drug change, it's worth getting the drugs checked quickly. But I think we do offer collars for comfort sometimes, and patients, it's very difficult to reverse it because it's often not about weakness in the neck muscles, it's about proprioception. So we'll do everything we can in terms of exercise and pillows and all that kind of advice, but we usually do end up offering a soft collar. Not everybody tolerates them, but the head up collar can be quite good, which was ultimately made for people with MND, but it's made out of the material that they sent astronauts to space in, so it's quite soft against the skin, and they put the things that hold the neck in the right position are sort of stuck onto the sides and then molded. But I haven't really found many patients that have even tolerated that, because by the time they've had it for a while, it's difficult. But that, and again, that's why we want to try and catch patients as quickly as possible and stop their posture getting worse before it starts.
Brilliant. Thank you so much. I'm assuming there's no more questions. I'll speak very slowly, and in case anyone wants to put anything more in the chat, but just wanted to say thank you so much on behalf, and I know Emmeline, I told Emmeline she could do the closing, but now I'm stealing the thunder. But I just want to say thank you so much on behalf of the North Committee. We really, really appreciate you coming to talk to us, Fiona. And you know, your insight into Parkinson's is second to none. So yeah, we really, really appreciate that. And you know, everybody's saying thank you in the chat, and what an excellent session it's been. So yeah, really, really appreciate you coming. So thank you.
Welcome. If anybody's got any questions afterwards, just email me. It's fine. You might not get an immediate response, but
Brilliant. We will try our hardest to disseminate the slides and the reference list that Fiona shared with us. So we'll try and get the comms officers to send that out. And like we said, please fill in the feedback form, because it's how we get feedback from these events. You know, if there's anything you would like to change, or if there's anything that you might want covering in the future, you can put on those forms. And then when we've released them, then we can send out CPD certificates as well. Is there anything else I've forgotten, Verity, or are we good? No,
I think that's everything.
Wonderful. Well, thank you guys so much for joining us. We really appreciate it. All right.